A patient sits down in your consulting room, and before they say a single word, you notice something unusual. One eye appears to be visibly bulging forwards. It's one of those striking clinical signs that, let's be honest, might cause a tiny moment of internal panic. But don't worry, welcome to this explainer for Everything Optometry. Today, we're going to treat this exact scenario like a clinical detective challenge, giving you the tools to confidently figure out exactly why that eye is protruding. You see, that single sign could indicate an autoimmune disease, a bacterial infection, a tumor, or a vascular emergency. So the real question is, would you know which one needs an immediate, same-day emergency referral? Because making the right call here could literally save a patient's sight or even their life.
To turn you into an expert clinical detective, we're going to structure today's investigation into these 6 key stages: the proptosis mystery, gathering your clues, looking at TED and tumors, the cellulitis and CCF emergencies, the referral decision, and a final case challenge. Let's get into it.
All right, Section 1, the proptosis mystery. Let's quickly understand the mechanics of the bulging eye.
By definition, proptosis is simply the abnormal protrusion of the eyeball due to increased orbital contents. But why does it happen? Well, think of the bony orbit of the skull like an overfilled suitcase. It's rigid, it's unforgiving. If something new gets added inside that closed space, whether that's severe inflammation, a growing tumor, or vascular swelling, the eye just cannot expand backwards or sideways. The path of least resistance is forward. So the eyeball is quite literally pushed out of the socket.
Moving right along to Section 2, gathering your clinical clues. This is your history framework.
The questions you ask here are the questions that reveal the cause. You've got to act like a detective and interrogate those symptoms. Was this sudden, or has it been a gradual bulge over a few months? Is it one eye or both? Are they in pain? Because pain drastically raises your referral urgency. You also need to actively hunt for red flags. Ask about high fevers, double vision, blurred vision, or any known thyroid issues. And absolutely always ask about recent head trauma. As we'll see in a minute, a recent knock to the head can trigger a life-threatening vascular leak behind the eye.
Once you've got your history, you need a flawless, structured physical exam. Start with visual acuity. Do a cover test. Rigorously check ocular motility for any mechanical restriction. You absolutely cannot skip checking the pupil reactions. Missing a relative afferent pupillary defect, or RAPD, means you might be missing severe optic nerve compression. Finally, do a thorough external and corneal exam. An eye pushed out of its socket tends to dry out rapidly, leading to severe exposure damage. Missing any of these steps is a massive pitfall.
Okay, Section 3. Let's officially meet our suspects, starting with TED and tumors, the typical white eye causes.
This is a fantastic binary sorting trick for your exams in clinic. Categorize that bulging eye right away. Is it white and quiet, or is it red and angry? A bulging white eye points us toward chronic, quieter issues, like chronic thyroid eye disease or a slow-growing orbital tumor. On the flip side, a bulging red eye screams active danger. That's your active TED, a severe bacterial infection, or a high-pressure vascular anomaly.
Let's look at thyroid eye disease, or TED. This is the single most common cause of adult proptosis. It's an autoimmune disease where orbital tissues expand and the extraocular muscles massively enlarge. Because it's systemic, TED is actually the main cause on our list that typically presents bilaterally, affecting both eyes. So here's your golden memory tip. When you see lid retraction, that classic staring appearance, combined with proptosis, you need to think thyroid until proven otherwise.
Let's dial up the urgency with Section 4, emergencies. Cellulitis and CCF. These are the red eye dangers. These are the cases that should make your heart skip a beat. Picture a child presenting in your clinic with a swollen, incredibly painful eye, a high fever, restricted motility, and double vision. This is orbital cellulitis. It is dangerous. The swelling builds massive pressure, putting the optic nerve at huge risk. Listen carefully, this is an absolute emergency, not a routine referral. If you ignore this, the infection can easily spread to the brain, leading to meningitis, a brain abscess, or cavernous sinus thrombosis. Our final highly dangerous suspect is the diagnosis that students most often miss, the Carotid-Cavernous Fistula, or CCF. This frequently pops up after a recent head trauma. The patient comes in with a very red eye, blurred vision, and quite uniquely, pulsatile proptosis. That means the eye is visibly bulging and pulsing in time with their heartbeat.
Plus, they might mention hearing a rushing or swooshing noise in their head, which we call a bruit. If you hear a bruit and see proptosis, think CCF.
To understand why a CCF looks so dramatic, imagine a massive plumbing disaster. An abnormal connection forms, and a high-pressure artery starts leaking directly into a low-pressure venous plumbing system that absolutely wasn't designed to handle that kind of pressure. This causes massive venous congestion. The orbital pressure skyrockets, forcing the eye out, and the massively enlarged sinus compresses the vital cranial nerves running right through it, causing that double vision.
All right, Section 5, the referral decision. Let's talk triage and urgency.
You've gathered your clues, you've found your suspect. So what do you do next? Use this traffic light system. Red means same-day emergency referral. Sudden, painful conditions like orbital cellulitis and carotid-cavernous fistulas go straight to A&E. Orange is an urgent one-week referral. This is for things like active thyroid eye disease presenting with pain and redness or a painful orbital tumor. Green is your routine referral, reserved for quiet, chronic cases like stable TED without any corneal exposure issues. And remember, if you are ever in doubt, pain, blurred vision, or sudden double vision always bumps up your urgency.
Section 6, the clinical case challenge. Time to test those diagnostic skills.
Let's do a rapid-fire quiz. Look at the clues. Case 1 is a patient presenting with bilateral proptosis and very obvious lid retraction. Case 2 is a child with a really painful, swollen red eye and a high fever. What is your most likely diagnosis, and what is your referral urgency for both? Lock in your answers.
Let's see how you did. For case 1, those bilateral staring eyes almost always mean thyroid eye disease. The referral urgency just depends on if it's active or chronic. For case 2, that painful, feverish swelling is textbook orbital cellulitis. That demands an immediate, same-day emergency referral.
Let's try 2 more. Case 3, a patient with recent head trauma, a red eye, a rushing bruit sound, and pulsatile proptosis. Case 4, a gradual, progressive, but totally painless proptosis developing over several months. Think back to our plumbing and suitcase analogies. What are your diagnoses?
For case 3, that rushing bruit and pulsing eye points right to a CCF. It's a high-pressure vascular leak and a same-day emergency. For case 4, a slow, painless bulge in a quiet white eye is the classic presentation of an orbital tumor, which usually means an urgent or routine referral. Before we finish up, let's look at the common exam mistakes that trip up clinicians. First, confusing mild preseptal cellulitis with dangerous orbital cellulitis. Never underestimate a swollen eye. Second, totally forgetting to check ocular motility. Third, skipping the pupil exam and missing an RAPD. Fourth, missing a CCF entirely because you forgot to ask about a bruit or a history of trauma. And lastly, simply underestimating how urgently a patient needs to be seen. Here are your rapid-fire final takeaways. Proptosis is a sign, not a diagnosis itself. Sudden, painful proptosis is a massive red flag. Thyroid eye disease is your most common adult cause. Orbital cellulitis is an absolute emergency. Orbital tumors usually creep up gradually, and CCFs have totally unique vascular signs, like bruits. Keep these pearls in mind, and you'll easily navigate any proptosis case.
We often just think of the eye as a camera, but with proptosis, the eye is acting as the ultimate pressure gauge for the brain and the body. So the next time a patient walks in with a bulging eye, don't just see the cosmetic sign. Ask yourself, is this revealing a systemic immune attack, a spreading brain infection, or a high-pressure vascular leak? The clues are all there waiting for you. The real question is, are you ready to read them correctly and save their sight?